under health insurance, you can get coverage for allied health services and a range of services outside of the hospital system. And they usually allow so much per person for eyes, teeth, allied health services, physiotherapy. So private health insurance covers just 1/3 of the most disadvantaged group because they can't afford it, 20% of the population. But the people who can afford it, it covers about 79%. So the argument, the debate here is, can we afford private health insurance? Why should some people have that and other people don't have that? And so there is a public debate. My view is we're a mixed economy. We have private and public sectors, and we should have some interplay between both of them in the health system. But other people argue strongly that all the money should be in the public system. What's happened, Bridget? The pharmaceutical benefit scheme in Australia...
David, I think some of us may have some questions.
Oh, okay.
Right?
Someone have a question?
Any question? Yes, please feel free to interact, because I asked Professor David that during his presentation, maybe some of us would like to ask something, and he allowed.
Certainly, yeah.
Yes, please.
Yeah, I'm Suprasit. It's interesting to learn about the Medicare levy, or I may put in the terms of a health tax. So, please discuss. I think it's implemented many decades before. Yeah, at 1%. At the start, how the political decisions or the supporting of the people in paying this Medicare levy, and during the history you have presented that it has increased a bit from 1%, and in some cases, as you said, it's a favor private health insurance. That means who had private insurance, they pay less as compared to those who don't have. So these are the dimensions that we are discussing a lot within the Thai healthcare system, whether we should have an alternative source of finance.
I think to answer that, my view of life is that there are opportunities that come along, and there are people that come along who want to make a difference. And sometimes the time's right. Now, I'm sure everyone in Thailand has heard of Gough Whitlam. No? You don't know Gough Whitlam? Well, he was a Prime Minister back in the 80s, early 80s.
Gough Whitlam, right?
Gough Whitlam, yeah. And he was from the Labor Party, which is left of the centre, okay? And he came to power, and his theme in the election was, it's time, right? And he was a very large figure in public life, and he was very convincing. And he told the Australian people it was time for change, get rid of the Conservatives, let's do this for Australia. So a very powerful speech, and he introduced Medicare on that basis, and the public supported it strongly. And it was part of major reforms in the way Australia was governed at that time. Very significant time of change for Australia. And the public loved it because it was supporting them and giving them good health. So the only objections really were from the medical and the people who believed in the free market on the right. So it went ahead and it wasn't challenged. But when there was a change in government to a right-wing market, they tried to get rid of it. But it had become embedded in the psychology of Australians. So they made changes to it, but it essentially remained in place. And then when Labor got back in later on, they reinstated what the Liberals had stopped and increased the importance of Medicare. So it's survived different politics and it's been chopped and changed a bit, but fundamentally it's stayed the same. The extent of the levy doesn't really matter because it signifies that people are paying a tax for their health care, and I don't think most Australians will know it's only a small part of what's being taken out of taxes to pay for the whole system. What they see is they're making a commitment to their healthcare system and they're entitled. And it's a big entitlement. Now, when the current government came in, they looked at the Treasury books. They said, oh no, we've got all this debt. Those terrible Labor people, they spent all our money. And the debt burden for Australia is so huge, we're going to have to cut back on public expenditure. Now, when you've got a majority of one, that's a very dangerous thing to do and not very easily achieved. And I think they'll struggle, but they're trying to contain the expenditure wherever they can. They also, and this is poor public policy, they also decided they're going to move to the market and try and use the private sector more to deliver services without telling the Australian people. So the Labor Party said, they're selling off, they're privatising, they're reducing our access. So in that election campaign, Mediscare became a very big issue. So much so that the government, who was planning all these market-driven changes, had to get up and say, no, we promise, we will never change Medicare. Medicare is here to stay. And as you know, when a politician makes a promise, you don't necessarily put much faith in it being a long-term promise, because our experience is that once they get back in, they're still going to try and do it. But it was a lesson to the government about hands off, we value and support Medicare, and those principles I talked about are really principles Australians aspire to. But I was very, I wouldn't say depressed, but I was very annoyed in the last couple of years, and I'm sort of a little bit to the right of the centre, that a government would try and make changes without signalling their intent and the reasoning for it. And I think that's why they had a big majority, down to one, because they tried to put in important public policy changes without taking the community with them or the community understanding what they're doing. So the Mediscare thing worked because the public was ignorant of what the government was doing. So we're not here to tell politicians what to do, I guess. Far from it, but that's an important lesson. Whether they learn it or not, I don't know. But their advisors and their senior bureaucrats should have some longer-term understanding of the implications and should give them advice. One of the things that I think is different about Thailand to Australia, and I may be wrong, but your public policy people and your senior people in the health system and I guess other parts seem to have a longevity in the system despite the politicians. Ours get tossed around a bit when there's a change in government, the bureaucrats change. When there's a change in government, the bureaucrats change, you know. So there's no understanding of the long-term public policy. It's more about doing what the minister wants. And I think your success has been, you've been more measured, more long-term. Your senior people have been around for a fair while, and irrespective of the politics, the system and the policy goes on. So I know that may be oversimplifying, but I think it's probably better balance than what we have in Australia in the public policy area. Okay? So, and that's part of the problem. I said, we've got all these states and territories, and the Commonwealth sort of engaged in trying to make the system work. So you can't import drugs and pharmaceuticals in Australia without the government's approval, right? And it can't be made available to patients and pharmacies unless it's approved by the government. And the government approves a generic version of drugs, not the brand name. and it saves Australia a lot of money. And it also regulates what's available across the counter. So it's a very powerful tool for us to control pharmaceutical costs. Now, the Americans will tell you that's restraint of trade because they want to sell their pharmaceuticals to us at a highly inflated price. So we've in the worldwide trade policy arena, we've withstood that charge and we've stuck with the pharmaceutical benefit schedule. Even having said that, we just published what we call a medical atlas of prescribing, and there are great variations in utilisation of pharmaceuticals across Australia and between regions and states, and some of our use is obviously overutilisation of pharmaceuticals in our system. So despite the fact we've got that good control, we've got a challenge to try and somehow redress the inappropriate and poor use of pharmaceuticals when there are better interventions that could be used before that to maintain people's health and not just give them medications and forget about them. So, besides the pharmaceutical benefits, people who are war veterans and their families get a higher benefit allowance because of the fact that they served Australia in different generations of war. And also, out-of-pocket pharmaceuticals are capped. So if you have a lot of, you've got aspirin, you've got this disease, you've got that disease, you're getting a lot of tablets a long time, there's a cap so that you don't continue to pay high prices. So that's the detail. So the low income cost of a prescription was only $6.10 and annually $366. That's for low income earners. For the general population, it's $37 per prescription, and it reverts to a low income rate cap if you spend more than $1,500. And if you purchase something that's not on the pharmaceutical benefits schedule, you have to pay the full price. You get pharmaceuticals in the public hospital free, but you only get a starter pack. So when they're discharging you, they give you a small amount of pharmaceuticals and a prescription to go and get the rest yourself. So it's very limited. Righto, I'd now like to talk about primary care and general practice. The GPs are the cornerstone of the Australian healthcare system. There's the numbers that we have in Australia. Most of them are self-employed in small practices, about 4 GP per practice. The fees are set by the federal government, as I said before, on the medical benefit schedule. You don't have to register to go to a GP. You can go to any GP who has room to see you. Their books are open. But you can choose one doctor and stick with them in whichever way you like. They're the gatekeepers to the specialist healthcare system. So you don't go direct to a specialist, you've got to be referred by a GP. Okay. So choose your own doctor, it's fee for service, and we provide practice incentive payments to GPs if they reach targets for immunisation or if they complete aged care plans for the older people to try and keep them healthy and fit. So there are incentives to do preventative, promotional work in general practice. We've increased the number of nurses working in general practice because they can do a lot of the things, the routine things, and the doctors can see more patients. And they've got to ensure that aftercare services are available, but they don't necessarily have to deliver them themselves. So they generally share after-hour services for their patients between them. So, out-of-pocket payments accounted for 18% of total health expenditure. So that's what patients had to pay themselves. A lot of that was for medications, some was for dental care, and some was a gap payment between the medical benefit schedule and what the doctors wanted. But 83% of visits to GPs across Australia were provided without a charge. So you could argue that the largest percentage of the Australian population is getting free access to health care. And the patients where they have to pay the extra, it's about $31. And there are changes coming up in terms of putting safety nets over the top of that so people aren't entirely disadvantaged. Oh, sorry. So the current government, wanting to cut back costs, have set up a review task force to look at what Medicare, what is provided under Medicare and under the schedule, and they've been cutting things out that they think are poor practice, or where there's utilisation without a benefit outcome, and they're going through line by line to reduce what's available and what's ineffective out of that to save money. They're doing the same thing with pharmaceutical benefits scheme to make sure that the drugs are relevant, cost effective, and cutting out unnecessary ones. But at the same time, in their favour, they're putting on some very high cost, very expensive drugs for people that they were denied access to in the past. In Australia, we talk about avoidable and preventable admissions. There's a lot of evidence to show that a lot of things could be treated outside a hospital if we had better primary health care services. There's a lot of adverse events that occur in hospitals that wouldn't occur if we kept people out of hospitals. But there's a lot of debate, academic and policy debate, about what's avoidable and what's preventable. Because what was avoidable and preventable last year changes as practice and research and medications and technologies change. Yeah, of course we can do that outside the system now because we've got these changes, but we couldn't before. So it's not an easy tick list of, well, we won't do that in hospital anymore. It's a real discussion. And even in the medical profession, there are different views about what works and what doesn't work. So it's a complex area. But it's what we're doing. And they're trying to shift the system away from fee-for-service to capitation or lump sum payments for doctors to look after populations. That's the next big battleground for us, because the GPs like to be paid fee-for-service and run their own business, and they don't want to be controlled or owned by the government. In fact, our Constitution specifically says in the provision of health services, you cannot have conscription of people into the system. So the Constitution was written and designed to protect the doctors' independence and the way they operate. And you can't operate a health system without doctors. So it's a very strong point for them. So we're looking at how we improve chronic care, screening and prevention. We're very much looking at step care. In my primary health care network, we're setting up a program, a model of care for mental health as to how we're going to deliver in the future, because we've just been given a few $1 million by the government to deliver mental health services to our region, right? Now, they didn't say, here's the money and this is the service you will provide. They said, here's the money, you design a model of care that you think will work in your region, and you design it with the clinicians and the community, and then you go out to tender and you commission services from NGOs, other providers, to deliver that model of care in mental health. And we want you to do it so that it's not just one provider, but it's groups working together. So this is turning the system upside down. This is giving us at the local level an opportunity to decide how we deliver services. So it's an important change for us. So we're looking at step care, you know. If someone has mental health problems, identifying them, providing intervention, supporting them, trying not to go to the next stage of medication or, you know, other things, and trying to keep them healthy and fit and not having to rely on the acute care sector. So we're just going through that process now you talk about the hospital at the home, or the other term is health home, which is a really silly name, but we've just been picked to be a trial pilot to get some general practices, become the health home, enrolling patients, so they're part of that home with the doctors and the nurses and the physios, and paying them a capitation fee to look after that population. And the pilot will go something like this. We know these people have precursors or indicators becoming diabetic, and we know what they are, and it might be weight, activity, whatever. We want the GP and his team of staff under this system to identify those markers for a patient and try and work on preventing one or two of them from actually developing into something that will ultimately end up to be diabetes. So we're going to experiment with trying to, at the prevention promotion end, make the interventions that will stop the diabetes. So there's only about 10 trials across Australia, and we're going to set one up and give it a go. I'm not sure how the doctors will feel about it. There's some medical support, and I'm not sure that communities will understand it, but that's the challenge for us in the future. I've only got one slide on workforce, and I'll try and be brief about it. Workforce is a problem for us, and it's the same as the problem for most countries. It's increasing rapidly. As we broaden the definition of health and what services we deliver to people, that needs more staff, it needs different classification of staff. So workforce is going up. Our medical practitioners are similar to the average for OECD. We've got a higher per capita of nurses in our system, but the nurses tell you they're overworked. And unfortunately, all the health professionals want to live in the cities and at the beach. So we have difficulty in rural areas. The workforce is ageing. A lot of our health workforce is, getting to retirement age. And we have shortages, maldistribution, both now and into the future. And in rural healthcare, our health system depends on overseas trained health professionals. So we have a lot of overseas trained doctors and nurses working in our system in Australia, yet we have a very big program of training doctors and nurses for Australia. So in all things, you'll see Australian health professionals working all around the world, and you'll see Thais and Indians and Irish, all the nationals now working in the Australian healthcare system. So we're all part of the global workforce. So we transcend our national boundaries. Right. Been asked to talk about, please put your hand up if you've got a question, because it'll give me a break for a minute. But our public hospitals have been, which are run by the states, have been organised into networks or districts. And I'll show you that. And there's about 138 all across Australia. They vary in size, so if you're in Sydney, that might be a small geographic area. There might only be one or two major hospitals, whereas if you go to where I live, there are 20 hospitals in an area larger than Tasmania, and with 4-hour driving distance between one side to the other. Okay, so there's differences in the size of the districts, but they're called local, and local's a very important word because there's a principle called subsidiarity, which means services should be managed and governed as close as possible to the people who you serve. So we call the health districts local to reinforce the notion that they're serving a local population. It might be a big population, but it's local, and it's their responsibility and accountability to serve that local population, managing down and out, not necessarily up. And at the upper levels, it's more about policy and planning, monitoring and evaluation. That's the theory. We have activity-based funding, but as my colleague over here knows, we set up Australian diagnostic related groups for funding and costing of hospital activity many years ago. And it was used in Victoria, one state. It's used in Thailand for a long time, and Australia's just getting around to using it in the rest of Australia. So there's a good example of an innovation, something that was sensible, being adopted by other countries, and we're still implementing it now in Australia. So the debate about how much money the Commonwealth gives the state continues to go on, and they've set an agreement that they're going to fund 45% and the states are going to find the rest. And they're going to use the DRGs for that purpose, and the smaller rural hospitals get a block grant. So again, I just want to remind you that one of our problems is the divided responsibilities. So you've got the Commonwealth looking after primary health care and general practice, and we went from divisions to Medicare locals to primary health networks. They fund aged care and veterans care. The states run the public hospitals in local health districts, and local government looks after the water supply and sanitation. Any questions? The other thing in Australia, because we've got 7 or 8 states and territories, we've got 7 or 8 health departments and agencies and commissions on the right-hand side. And at the same time, at the Commonwealth level, we've got all those agencies, much as you do, to manage the healthcare system and the policy and the quality. So it begs the question, can a country of 24 million people support 8 health departments plus the Commonwealth bureaucracy to deliver health service, where in your case you've got only the Commonwealth, the national ones. So that's another difference that we have. So in Australia, hospitals and aged care was established many years ago by communities. They owned the hospitals, they built them, they ran them, and the government didn't really want to know about it. So if communities wanted to do that, that's fine. But increasingly, communities were going to government saying, I need more money to improve the hospital or to do this and to do that. And it soon became apparent that the government couldn't ignore it. They had to be part of the system if they wanted to control the costs of health. So the government slowly took control over decades of what was a community-based services. So we had separate health departments, health commissions, regions. We've changed the name of those organisations over the years. When I started work, I worked for a hospital which was standalone, had its own board, appointed its own chief executive officer, and we worked very hard for our community. We didn't take much notice of the government unless we needed the money. Okay, so that, and everyone wanted to have the best hospital in Australia. They all wanted to be the Mayo Clinic. And of course the government saw that that was an impossible dream in terms of financing in the long term, and they started to take control to better organise, to have a system of healthcare rather than a focus on facilities. Right? So everyone's not going to have a Mayo Clinic, but they're going to be accessible enough to use and be referred to for all Australians. So that was a significant change point. I was fortunate back in the 1970s. I spent some time at university studying health administration. I came back, and this is the time of Gough Whitlam, who started Medicare, and he gave us millions of dollars to establish community health services in Australia. And I got the job of doing it for part of New South Wales. So I was young, enthusiastic and impressionable, and I had all this money to spend on setting up health centres, employing staff, buying cars, engaging with the community and getting a whole system set up for a region. So there's not many times in your life that where money's not a problem, right? Or where you have unfettered access to money to get things done. So that was a very enjoyable part of my career. But like all good things, they came to an end once the pilots were established and put in place, and people realised that we had to manage better with what we have rather than necessarily getting more money all the time. So we moved from the pilots, which were small in scale, to health districts in rural areas, and then area health services, which increased the scale. So I started off in the pilot with an organisation. I was the deputy, 5 hospitals and 2 shires, so it was on the coast. When I went to Tamworth in rural New South Wales, I went from managing 2 hospitals, the major hospital, to managing a district of 8 hospitals, which then changed to an area that had 20 hospitals. And all that happened in about a 6-year time frame of change. Right? So we went from small standalone to small pilots to medium-sized to large-scale area health services. Then the government in New South Wales decided that they were going to run everything directly. So they still had the area health service, but it didn't. They got rid of the board. The chief executive was appointed by the minister, and they tried to run everything from Sydney. Okay, and it failed miserably, and it demonstrated to everyone the importance of good governance at the local level and engagement with communities. And I'll say a bit more about that, but that's the important thing for us all to remember. The more distant you are from where the services are delivered, the easier it is not to understand the problems, but you create dissent, discomfort, people feel devalued, and things start to go wrong. So if you've got good managers and good governance locally, what's happening is going to be more noticeable, and people are going to be held more accountable, but they'll also be more responsive to changes at the local level where the services are delivered. So I talked about the pilots. Then I went to 17 area health services, the board and the CEO. The difference was the board and the CEO were appointed by the Minister of the Government. So we lost a fair bit of freedom and independence and were there to do what the government wanted us to do. Okay? Then the problem set in when they went to only 8 area health services for the whole state. Very big organisations, and they took away the boards. Queensland, another state, did the same thing, central control. So we went from high decentralisation to a reasonable level of decentralisation, back to high centralisation and central control over that period, about 20 years. Sorry, I've got the slide somewhere, but when they went to the 8 area health services and the central control, we had some really bad adverse events in our hospitals, really bad. We had a very dissatisfied staff. We had a very high turnover of chief executives, massive turnover of people, very short time frames. So much so, it was politically embarrassing, and the government had to set up a judicial inquiry, not just a review, a judicial inquiry into the health system in New South Wales and in Queensland, where a lot of people in one hospital, Bundaberg, died as a result of an incompetent medical practitioner who should never have been registered to practice but was. So we had these judicial inquiries, and that recognised the subsidiarity, the localness, the engagement with communities, the engagement with clinicians. Clinicians felt devalued and unwanted, and so it needed to bring them back into the system. They used to be there. In this process of reform, they were left out, and we got bad outcomes. So now we have a whole load of support for training, education, monitoring and reporting quality adverse events, and a greater empathy between the medical profession and communities as well as the hospital staff. So the lesson is, if you're going to argue about decentralisation or centralisation, know what the implications are and what the potential benefits and negative outcomes can be. And there's no right answer. It's something you'll come to discover, but don't be too radical in it. Do it gradually and sensibly, and I think you've got to connect services together that link together in a geographic region that thinks of itself as being part of a region. So important point there about how you devolve and develop local health districts, such as you're doing here. So just very briefly, we had, on the left-hand side was when we had the smaller networks and districts. Then we got to the 17, so you can see the increase in size. I'm up in the New England there on the right-hand side, that's where I live. And then we went to the 8 area health service, so you can see how massive some of them are. Oh, righto. He wants me to use the toilet. So I live up there. So they've gone to the bigger ones. And then after the judicial inquiries, we came back to this more local health district thinking. And this is where we are now. So I'm part of the Hunter New England. Oh, I can't see it, but it goes from the coast up. It's about an 8-hour drive. Australian style drive, not tile style. 8-hour drive from one side to the other. Big teaching hospital down on the coast. My hospital in the centre there is a large referral hospital for the rural areas. Sydney, see that metropolitan C breakout map? Sydney's that white area on the right-hand side, and then it's shown over there. So Sydney's in the left hand. That's Sydney. Okay. So that's the hospitals. Okay, so hospitals are in a system called a local health district, and the managers manage the system as well as individual hospitals. General practice, always been out there on its own, in many respects unsupported and uncared for. And in the late 1980s, government decided they better do something about general practice because it was at a stage where it might fall over because it wasn't supported. The doctors were getting older, they were working alone, and they weren't part of the system. So they formed divisions of general practice. So the doctors became the board, they were given money, they employed nurses, they got IT support, they got education training, and they even delivered services. And the doctors eventually, initially resisted it, but eventually owned it because it was their division and they could decide what to do and they were comfortable. And just as that was working well and they were comfortable, the new government came in and they said, it can't just be about doctors, it's got to be about primary health care and all the professions and the community. So they changed.